to our last component, which is our special test. For the special test, I am going to be performing what is called the anterior shear or the sagittal stress test. This is a test that is going to be done on your neck area, and it will require me to place my hands around the back of your neck, possibly onto your shoulders and upper back, and probably around your head as well too. So the purpose of this special test is to assess the integrity of the ligaments of your neck, but there is a chance we might possibly provoke some discomfort for you. You might feel like you have a lump in your throat, you might feel dizziness, nauseousness. So if you feel uncomfortable at any time, just let me know and we'll modify things accordingly. The benefit of us doing this assessment is that it will give me information about your condition and will help me formulate a proper treatment plan for you. Do you have any questions about what we're doing so far? Awesome. Do I have your permission to continue? Perfect. I'll get you please lay down on your back with your head at this end of the table. All right, so according to your notes, according to McGee, you are supposed to apply this special test through all of the segments of C1 through C7. Have you guys done the transverse ligament stress test yet? Stress test yet? No. Transverse ligament? Why is it going to anterior shear first? Let me just quickly double check to make sure there is no transverse ligament stress test on this one, because I will do that one first then.
Okay.
Well, that's just gonna, great. Okay, cool, no worries, we'll figure it out. The reason why I'm asking is because the transverse ligament stress test and the sagittal shear test, or anterior shear sagittal stress test, they look identical, and you are performing the same motions. It's just your landmark that is different, okay? So, because we know C1, C2, we have the C1 resting over top of the C2 dens, right? So if we were to push this, I don't know if you guys know this, but the dens actually rests on the anterior aspect of the vertebrae. So with Neilwyn facing upwards like this, his C1 is here and the dens is against the anterior aspect of the vertebrae, okay? So if I were to push forward on C2, it would literally push the dens into C1. Right? So there is no ligament of C1, C2 that's being tested because you are pushing the C2 into the C1. They are both moving forward. Right? So to push forward on C1, as you will learn, that is actually how we do the transverse ligament stress test. So that's not necessarily anterior shear. You push forward on C2, it's just going to push the dens right into the anterior arch of the vertebrae. So to effectively assess that anterior longitudinal ligament, it's most effectively done on C3 to C7. Okay, that is your practical application of it, but on test scenarios and everything like that, according to McGee, the special test is applied C1 through C7. But there is reasons as to why it's not as effective at C1 and C2, and I just told you why. Does that kind of make sense? Okay, so on paper, written test, this special test is for C1 through C7. For the purposes of practical application and actually doing it effectively, it is most effective on C3 to C7. Make sense? Cool. All right, so for this special test, you can start at either the bottom or the top. Your logic for deciding where you would like to start goes with your comfort level as a therapist. As you know, I like starting at the bottom and working my way up because I can just let go of the segments. Or it might be your patient's presentation. If you suspect that they have more instability or more mobility in the upper C-spine, you would be more inclined to start in the lower C-spine. If they have more instability and you suspect the lower C-spine, you will have more motivation to start further away and work your way towards it. Does that make sense? All right, so for the sake of the fact that hopefully nobody here has actual instability, just right now, just go ahead and treat according to what feels good to you for hand placement and functionality, okay? Okay. So landmarking for this anterior or sagittal shear test. Are you keeping your neck as long as I can? Good. So we're going to start with C7. So I have this most prominent SP. Neil, now you go ahead and lift up your head and look at your feet for me, please. Go ahead. Good. And back down. And again, do it slower for me. And back down. So his prominent one is C7. All right. So I'm on C7. I'm going to move just laterally. So I'm on, ideally, you want to be on the articular pillar. Okay. That's why we spend all morning landmarking and finding that articular pillar. Okay, if you can't quite landmark on the articular pillar, just do your best. Find that posterior aspect of their TBBs. Okay, so from here, I am not on their SP because that'd be really uncomfortable. I am lateral to their SP at the next bony prominence, lateral to the laminar group. So Neil, take a nice big breath in. and down. So I'm getting him to do that just so that he can relax his muscles, letting it go. Now, with this, there's two things that you can do. First thing you could do is you can push just anteriorly with your fingertips to move that individual segment. All right, second thing you can do is you could move anteriorly with just your fingertips and that segment, but also lifting with the head as well too. Okay, if somebody has a bigger head and you feel like it's kind of heavy and you have smaller hands or weak fingers, then you might be more comfortable with just pushing forward on the individual vertebrae. But if the person on your table has a little bit smaller head, you have big hands in comparison, you might be able to get away with actually just lifting the entire unit. Does that make sense? Good. So there is no element of cervical extension happening here unless I'm just pushing forward. It just naturally drifts his head into a slight extension. I'm not actively trying to extend his head. Okay? So we push forward anteriorly. It should be a firm stop as the ligaments are resisting that force. Okay, so we got a nice firm stop here, no dizziness, nauseousness, we're all good? Good. And then we move up to the next segment, again, so there we go, and then the anterior check. Good, nice and firm. And the reason why we want to start further away from our suspected segments is the first couple segments we will be testing will give us an idea of what the segments should feel like. So it's nice and firm, nice and firm, nice and firm. Oh boy, that's not stopping. That's how you know that there is some instability or that the integrity of those segments are compromised. So a positive for the special test is a recreation of nauseousness, dizziness, a feeling of a lump in the throat, as well as for you as practitioner, you will feel a soft end feel. So you should feel a firm stop, stop, but then if you go and it just keeps going, don't see how far it'll go. Just observe the fact that it has gone further than the others. And that should be enough for you to know that that is a positive. Okay? So ideally you would test as many segments as is necessary. In practice, you'll assess all of them. For your OP situation, you will probably do 2 or 3. Just keep going until we tell you to stop. Okay? Indication for this special test is patient talks about apprehension with movement. They've talked about how they've had a history of a motor vehicle accident or an injury to their neck. Right? Indication is not whiplash. Indication is they were in a motor vehicle accident. They have apprehension with movement. All right? Tissues being stressed is the anterior longitudinal ligament of the cervical spine. Any questions about this special test? All right. I can bring up my remote. There you go. Let's see. And the next one is. What's the number? Did I kill it? No. Yeah, if you can. Oh, there we go. That's the last one?
There's only one special test in this.
Okay, cool. And then we're just going to go into the cervical stabilization exercise. Why were you not working?
Maybe I locked it.
Oh, there we go. Got it. All right, so nice and briefly. In terms of cervical instability, it's most likely going to be your whiplash or motor vehicle accident patients that you will be using these exercises for. So what is the remedy to instability? Strengthening. All right, if the area is unstable, cannot support itself, the muscles have to double down and support it. So we have to strengthen the area to increase stability. Make sense? Great. Okay. But if somebody just had an accident and they're apprehensive with movement, are we going to get them to load up a 10-pound dumbbell and do like neck curls and all this stuff? Hopefully not. I really hope you don't tell them to do that. So instead, we are going to utilize micro pressures and gravity. Okay, so keep in mind that the exercises we are going to go through, it will say specific for flexion, specific for extension, etc., etc., etc. But you can turn the flexion exercises into extension exercises and vice versa. You just have to change whether you're going in flexion or extension. Nice and easy. So, starting with, oh, come on. There we go. That worked. Great.
What is micropressure?
Like it is you like
apply it?
yes,
Okay.
you are applying it, or you can give this as home care and you can get your patient just to apply literally 1 or 2 fingers worth of just gentle pressure.
Okay, that's-
Yeah. So
I've
it's
never
not like
used
a
the word
oof.
micropressure.
Well, because I mean like we're gonna apply pressure or just like a
Yeah.
little bit of pressure.
Yeah.
Right? Micro pressure. Alright, so cervical extension stabilization exercise. Actually all of you can do this exercise at the same time with me. So patient's gonna be seated, and you can either do this as part of treatment in the treatment room, or you can give this to them for homework. So what you wanna do is you are going to get your patient, or you, cup your hand behind your neck with the intention of trying to just exaggerate that lordosis a little bit. So this is a general neck extension exercise. So when you have that gentle extension, you're gonna get your patient to take 1 or 2 fingers to the back of their head and push forward, but using their neck muscles resist for 5, 4, 3, 2, 1, and relax. Good. Right? So this is for very general. We would say that we would use this as like the more early subacute stage of injury healing. The second stabilization exercise in extension is now going to be more specific. The first one was using the entire cupping of the hand to envelop the entire C-spine. But now the second stabilization exercise is you're actually going to use 2 fingers as a fulcrum. Okay, you will notice there will probably be a little element of lateral flexion when you do this one, so feel free to do both sides rather than just once, okay? So taking 2 fingers on one side, you can choose either the base of your skull, the middle of your neck, or your lower C-spine to create that fulcrum. Each position will have a different amount of flexion to target that area, right? Once you've found your specified area, whether it's the upper or the middle or the lower, you're gonna do the same thing again. Gentle resistance on the back of the neck, hold for 5 seconds, and try and resist. So depending on where you had put those 2 fingers on the back of your neck will determine which area or which segments are being specifically targeted. Okay, so those ones are more probably going to be for home care. We've got 2 more exercises which I would suggest you utilize in treatment. It worked last time. See? So this one is an extension exercise, but it can also be used as a flexion exercise as well too. All right, we're just going to quickly demonstrate this technique as well too. It will require me to place my hands around your head. May create discomfort. Let me know if it does, but it'll help me demonstrate stuff. Do you have any questions? Do I have permission to continue? Beautiful. Okay, to leave the face down, please. Okay, so this one, you're going to take this one in increments. Somebody said, I was in an accident 2 weeks ago. All right, we're going to start very, very, very gently. After we do some treatment, we would like to activate some of these muscles. So what I'm going to do is, Neilman, I'm going to go ahead and gently lift your head off of the table. And when I say so, I'm going to gently release some of my support, and you are going to have to use your muscles to hold your neck a little bit. We're going to hold that for 5 seconds, and then we'll have you gently put your head back down. If you feel uncomfortable at any time, you just let me know and we can stop. All right, any questions about that? Perfect. All right. So I'm going to gently bring his head into extension. And for somebody who's in an acute or early subacute, you're not going to just fully let go. I'm going to say, okay, Neil, I'm going to gently let go a little bit of pressure, and you're going to hold some of your head weight. Ready? And 5, 4, 3, 2, 1. Relax. I re-support his head, and we can put it back down. So my hands literally did not even come off his head, because all I was doing was releasing some of the weight of his head, right? The next step, he comes in 3 weeks later, he's like, yeah, I feel a little bit more comfortable with the movement on my neck. Still not great, still painful, still restricted, all of this good stuff. But he's able to support his head a little bit more. So, Neil, we're gonna go ahead and do that exercise again. So we're gonna lift his head, good, nice and gentle, into extension, and I'm going to let go a little bit more weight. 5, 4, 3, 2, 1, and relax back down. Good. All right, we continue with treatment. He's like, you know what, that actually wasn't too bad. All right, so we'll take it one element even higher. Now this time, Neil, when we do this, I'm going to actually fully remove my hands from the side of your head, and you are going to support the full weight of your head, okay? Ready? And right here, okay, I'm going to let go right now. 5, 4, 3, 2, 1, relax, good. And my hands were still right there, though, just to assist if needed. All right, so purpose of that is to help fire those neck muscles. Once I got to a point where I actually brought him into extension and let go, how do you think we can make that exercise one step more difficult?
So magic.
Did you lift his head?
I lifted his head.
Then make him lift it.
Make him lift it. You got it. And then isometrics. Yeah, all right, Neil, and I'll get you to nice and gently go ahead and lift your head off the table to try and look in front of the table. Good. 2, 1, relax back down. Very good. So once he's able to do that, Then we can start going into actual concentric contractions, right? First, starting with isometrics, where it's a gentle resistance. He could apply a little resistance. He can put a pillow on the back of his head. I don't know. Figure something out, right? And hold against a gentle resistance without movement for 5, 4, 3, 2, 1. What is the next amount of, like the next step of resistance? Close. So after isotonics, after isometrics, we've got isotonics, which means it is a maintained, steadily applied amount of pressure throughout the entire range. So isometric, sustained pressure, but you're not moving, it's just an isolated contraction. Isotonic is now, it's a contraction in movement, but we're not increasing any sort of pressure. Right? Followed by full concentric contractions, and then eccentric contractions. Okay, so that's how you're just slowly increasing the resistance and increasing the difficulty level so that your patient's muscles are continuously increasing in their challenge. Does that make sense? Great. How can we turn this into a flexion stabilization exercise? Supine. All right, Yolanda, you go ahead and turn yourself onto your back, please. And then it would be exactly the same thing. Lifting the head into flexion, releasing a little bit. Lifting the head into flexion, releasing a little bit more. Bringing the head into flexion, fully releasing, but still there to catch. And then lastly, he will be able to lift his head on his own. All right, any questions about that one? Nice and easy, right? And then lastly, flexion stabilization.
You just went over that.
That one is, okay, so that was just chin tucks. So with this one, all you need to do, this one's focused specifically on flexion. Ideally, you would get a rolled up towel underneath the base of the neck just to encourage that nice neutral extension. Nice neutral extension of the neck. Right, so a little rolled up towel would be ideal. From here, you're gonna get your patient to just start off with just chin tucks. So capital head movements. So starting with some chin tucks just to get those deep cervical flexors initiated. As he feels like, you know what, that's okay, then he can start to lift a little bit higher to look at his toes a little bit. Go ahead and chin tuck and lift. Oh, he can go all the way, yay, he's cured. He would do it in increments, right? And then eventually he'd be doing full neck curls. Then we can apply an isometric, and then he can do isotonics against my resistance, and then we can even do eccentric contractions by the end of it. Make sense? All right. So we are going to pair up when I say go. And once you've paired up, you're going to practice your consent for the special test.